My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan. And this Learn and Share conference call is on epilepsy surgery. And we're very, very happy to have with us Dr. Chaim Colen from Beaumont Health System, who's a neurosurgeon there. And he will be telling us all about epilepsy surgery, the different types, and what to expect going into it, what to expect afterwards. And hopefully this can, and I know we have a mix of people who've already had surgery and then some people who are considering surgery, so hopefully we can all learn from each other on this call. And we hopefully should have some other people joining the call later on. So Dr. Colen, if you can just introduce yourself and give a brief overview of your experience with epilepsy surgery, that would be great.
Certainly. Well, good afternoon. I'm in the ICU, so in case someone comes in here and disturbs me, my apologies.
Okay.
I just took a little quiet room on the side. So, I am Chaim Colen, and I'm the Director of Neurosurgery and Epilepsy Surgery here at William Beaumont Hospital in Grosse Pointe. And I graduated medical school in 2002, and I've been very keen on assisting people that have a need for epilepsy surgery since I've been doing my residency. I can tell you that for me it's been an exhilarating experience to assist those that have a lifelong disease that is a challenge to work with. And I look forward in trying to answer any questions that some of you may have at the end.
Okay, great. Let's start by, if you could just give us a quick overview of the most common types of brain surgery for epilepsy, and when they're used and in what types of candidates. And then for most of this discussion, we'll really be focusing on temporal lobectomy, since that's really the most common type of surgery. But if you can tell us about tell us a little bit about that, and then also some of the other major types of epilepsy surgery. That would be great.
Certainly. Well, the most common procedure or surgical procedure that is done for epilepsy is the intermedial temporal resection. Another term, or a very technical term for this, is the amygdalo-hippocampectomy, in which you remove the amygdala and the hippocampus, which generally would kindle or incite seizures in the majority of these patients that have the temporal lobe seizures. This is the most common type, generally for mesial temporal lobe epilepsy and a slew of other epilepsies that are localized inside the mesial temporal lobe. Other surgeries that are performed for epilepsy would include corpus callosotomy, in which this is a palliative type of procedure. So palliative meaning it's not a curative procedure. Corpus callosotomy divides the corpus callosum, which is a structure of the brain. Russ, can I ask you, is there a way that I could maybe show images here or not?
There isn't yet. We haven't got that technical yet, but
okay.
Yeah.
Okay.
Hopefully we can. We do have the capacity to do that through our new phone system, but we haven't given that a try yet. So that's on the horizon.
Okay, that's wonderful. If you can see the structures, because I know it's very esoteric when I'm talking about some of these things, and even difficult for myself because I'm trying to envision, right, so all of these structures as we go through. But essentially the corpus callosotomy is dividing your brain in half, and what's done is the interior 2/3 of this corpus callosum, or this structure of white matter fibers that unites the brain from one side to the other, is divided in surgery. The idea, and why I said it's a palliative type of procedure, is that it divides and does not allow seizures from one hemisphere to travel to the other hemisphere. So what it's doing is it's stopping the seizure from traveling and generalizing into a generalized tonic-clonic seizure, as one example. I can tell you that. Others are the modified hemispherotomy. There's the multiple subpeel transections. And the multiple subpeel transection has a limited application, really. It's generally used over areas of what's called eloquent cortex. And what I mean by eloquent cortex would be cortex that is involved with motor, with sensory, or that which you would not want to risk losing. So one would not want to be hemiparetic after a surgery, as an example. So someone that has the need for doing a multiple subpeel transection, which is kind of taking the PIA arachnoid layer. Wow, this is very difficult to explain on the telephone, but I can tell you that the thin layer that's covering the brain, what is done is you are isolating this little tiny circular region of the brain from allowing the axons to travel and ignite other areas of the brain. So it's kind of like if there's a wildfire, right? So we go around and we destroy part of the forest in order to salvage and stop the fire in its path. So this is kind of what the multiple subpeel transection. So what the transection does is that it divides the good brain from the bad brain and isolates the bad brain, but you're not really removing the bad brain, because if you would, then you would likely have a deficit.
Right, right.
I can tell you that where it has been shown to really be of benefit are in patients that suffer from the Landau-Kleffner syndrome, and those patients suffer from speech arrest. And so if you're going to do surgery on the speech area, you don't want to remove the speech area, but what you would like to do is essentially isolate the speech area from the other parts of the brain.
Makes sense. And what about both occipital and parietal and frontal lobe surgery?
So that would be like the extratemporal lobectomies. What's very interesting in those is that one has to be very, very careful, and the reason is that sometimes there can be misreadings from the epileptologist, and that is why in a lot of these cases there can be, or there's a higher rate of failure, and that would answer one of the questions that might be below or later on as we continue through the discussion, how many of these patients benefit from the epilepsy surgery. And it's about 75 to 80%, and this depends on the different studies. But with extratemporal lobectomies or what's called excisional lobectomies, where you're just removing areas of the brain that might be diseased, sometimes there's not such a high cure rate. So the cure rate sometimes is not as high or not as good because you cannot remove all of the brain tissue that you would like to preferably remove.
Right. We had a couple people join us partway into the call. Who joined us a few minutes ago?
I did. Paul Benedict.
Hi, Paul. And this is someone else?
This is Greg Schultz.
Hi, Greg.
Yes, how are you?
Fine.
Okay.
Yep, I just joined a little late, that's all.
And who's this?
Paul Benedict.
Okay, great. Excellent. Okay, so Dr. Colen, in terms of determining whether someone is a good candidate, what are some of the basic criteria that people need to meet to be considered for pre-surgical evaluation? And at what point really should patients start asking their neurologists about surgery?
Well, I would first consider medication. That's the first-line treatment for epilepsy, and someone that has failed medical management for their seizures, has failed 2 drugs, they should not necessarily be considered for surgery, but they might consider evaluation at a comprehensive epilepsy center. where they can be further evaluated in an epilepsy monitoring unit and thought, well, how can we further assist this patient in treatment for their seizures? In other words, gain better control of the seizures. And if we see after evaluation, and I will go through this evaluation, I would like to be a little bit more methodical on going through the evaluation. If we see that this patient would be a candidate, they go for another step, which would be a stage 1 in a phase 2. So we'll start in phase 1. So in phase 1, say someone is not responding to their medication. So say Mr. Jones is not responding to his medication, and he has been through a trial of 2 medications, and he has failed. Well, and he goes into an epilepsy monitoring unit, and you monitor for a couple of days. And the reason is one wants to allow seizures to occur while you are in the epilepsy monitoring unit. And during that period of stay in the epilepsy monitoring unit, you're going to be evaluated, maybe even to have the seizures induced if you don't have any seizures. So you might have lights, you might have drugs that induce seizures and kind of lower your seizure threshold. And during this period, if we see very accurately, well, we think that perhaps we might be able to help this patient. The seizures are not coming from an eloquent area of the brain. They're coming from an area that maybe we could remove. And to stay with a simple example would be, say these are temporal lobe seizures, and say we would be able to remove the temporal lobe, right? So one thing one has to be very cognizant about is that if we see it's coming from the left temporal lobe, then these cases can be a little bit more difficult. The reason is that speech in 99% of patients that are right-handed, their speech is going to be in the left side of the brain. Okay, so usually left posterior temporal lobe. So that's why one has to be very cautious if we think that the seizures are coming from the left side of the brain. Now, if we were to see that the seizures are coming from the left side of the brain, well, we would want to have a functional MRI study before we continue anywhere else. So the next step would be, well, once they're discharged back to home, well, we need to have this functional study in order to evaluate, well, is this person a continued surgical candidate? And if we go through that and, yes, indeed, we see that the person has the majority of their speech, and a lot of times it lights up as bilateral temporal lobes, majority on the left side. But if we have some on the right side and the right temporal lobe, so that is thought to be a very, very good candidate because they can further transfer some of their speech slowly over towards the right side. So the next step that we would go through is the person would need to be evaluated in a phase 2 setting. So this is where one needs to be evaluated. Are they a surgical candidate or are they not? And if they go to the phase 2, they're thought to be surgical candidates. What percentage of patients going from phase 1 move on to phase 2? I can tell you from my experience, a lot of it has to do with the academic setting. So the more they have workup as outpatients, as in the community, then a lot of patients that already might be thought as not surgical candidates, so someone that has pseudo-seizures would not be thought of as a surgical candidate. So quickly that is discarded because one would not want to operate on a patient that has pseudo-seizures. That's better controlled with medication, with discussion, and things like that. There's different types of therapies for someone that has a pseudo-seizures. Now, if we move on to the surgical phase, there's a stage, so now we're in phase 2, that's divided into a stage 1 and a stage 2. The stage 1 of the phase 2, so now that they entered into the surgical phase, remember I said there's 2 stages, the stage 1 and stage 2. The first stage is where they are going to have the implantation or the craniotomy for implantation of subdural grids and maybe depth electrodes. And these depth electrodes are electrodes that go deeper inside the brain and look to see exactly and very accurately pinpointing where the seizures may be coming from, especially in the areas of temporal lobe. We'll have to leave. Sorry, my phone here is ringing, but I don't know how to. We'll leave that alone. So now we move on to the stage 2 of phase 2. So say the person goes through this, and we find very accurately that, yes, indeed, if we remove this piece of brain tissue, the person would likely improve. We see accurately where the seizure focus is, then we would think, well, if we remove, we have to talk about it. And if we think that by removing this portion of the person's brain, there's going to be no deficits to the person, then we would consider removing that portion of the brain, and that's where we move to stage 2. We remove the depth electrodes, we remove the subdural grids, and now we consider actually resecting a part or a portion of the brain tissue. I hope I was able to be clear. I don't know.
Right.
Does anybody have any questions on that?
Any questions
What do you
about
think?
the pre-surgical evaluation process?
What is a pseudo seizure?
Pseudo seizures are patients that can have seizures, but they are not. So they can have what's called episodes, right, termed by neurologists as episodes, that the patient might think as a seizure, but they are not truly seizures by defined clinical criteria.
Right. Another
there's
term you might have heard of is psychogenic non-epileptic seizures is the other term that's used for that. So they're psychological in nature rather than epileptic in nature. So it's not caused by an electrical disturbance in the brain, but rather a response to psychological stress or psychological trauma.
Dr. Colen, I have questions.
Okay.
As surgical removal is done at the hippocampus or amygdala, what the deficit can be expected?
So you can have some retrograde amnesia. It's not very accurately and has not been accurately studied. I have had patients that say that it seems that their father has been learning things again. I have had patients say that they have forgotten a lot. I think it varies from patient to patient, and it all depends also how much was removed during the surgery. Other patients have no deficits whatsoever.
So that could be the risk of that surgery, I presume.
What are the risks?
That would be the risk of the surgery.
That's one of the risks. Other risks that one always needs to remember, because these leads are staying inside the brain for some time, there can be risk for infection, right? These leads are leaving the skin, leaving the scalp, and they're going outside of the brain. And so one needs to remember that there is always the possibility for an infection. Another thing that one always needs to remember is that there can accumulate blood also, and you can have what's called a hematoma that will accumulate on the surface of the brain. And those are the largest risks that have been associated with this type of procedure. Other very smaller risks would be a risk of stroke, right? So anytime you go into the brain and you're removing areas of the brain, you have to be very cautious which veins, if need to be removed, which veins they are, and which ones and where they are draining to. So if it's an important vein, it needs to stay.
Would you ever recommend somebody that's up in age
Yes. Oh, indeed. For epilepsy surgery, you're saying?
Yes.
Yes.
Somebody over 70?
Over 70? I would recommend that they would be evaluated, not necessarily thought from the get-go as a surgical candidate. But they should be evaluated, because if they can be assisted a lot, we don't just look necessarily at we have to look at the overall picture. So if they're a very functional 70, 75-year-old person, and we think that they're going to live for another 15 years, and we can improve their quality of life, right? So surgically speaking, I always tell my patients, something that is very important is that what is the reason that we do the surgery? We do the surgery to improve your current status. So if we feel that the risks the benefits would overweigh the risks, then the patient should have surgery. And all these are things that always should be discussed.
Well, yeah, excuse me, this is Clinton. I see what you're saying. I remember when I had brain surgery, I had it twice, but I had uncontrollable seizures first. But then I know as the surgery, I can tell now when seizures come on and everything. That's why my doctor now gave me the vagus neurosurgeon to take care of things right there, stop them.
Uh-huh. How has the vagal nerve stimulator worked for you?
Very good.
Very good?
Yes. So they come on, just sit down, and I press it on, it'll stop it, no problem at all.
Mm-hmm. Mm-hmm. Well, that's very good. Now, I can tell you that I agree with you. So you have had brain surgery before you had the vagal nerve stimulator, correct?
Oh, yes, I had brain surgery twice when I was in Children's Hospital.
Children's here in Michigan?
Yes.
Yes.
By Dr. Kennedy.
Oh, by Dr. Kennedy. Okay,
yeah.
I know her. Well, here's what I would always recommend: that a vagal nerve stimulator should never be implanted from the get-go. And just like I said earlier on during the discussion, someone that has had or someone that has seizures on both sides that are being generated on both sides of their brain, so from one hemisphere and from the other hemisphere, then those would likely be candidates for a palliative type procedure. I would recommend a vagal nerve stimulator. And then the other one that would be recommended is the possibility of a corpus callosotomy. So removing the corpus callosum, dividing the corpus callosum.
Okay, so again, we'll have some more time for questions, but let's talk about the actual surgery itself and how long it takes, who's involved, what type of preparation is required, and then a little bit about after the surgery, what patients can expect.
Sure. Well, you know something? I would like to do something that would be wonderful. Now, Russ, do you have everyone's email address? Because I could provide a link and a link to a surgery where everyone can watch the surgery. And I'm not saying right now on the telephone call, but I would be very happy to provide this link, and you can look at the surgery, and then you can always even write me if you have any questions.
Sure, excellent. Yeah,
now,
in fact, I've seen that video. So
oh, really?
Informative.
Oh.
So, yeah, if you would email that to me afterwards,
I'd love to. Sure.
Who registered for this call? That'd be great.
Sure. Well, here's what I can do is I can walk you through the steps. So I always use stereotaxis. And stereotaxis is kind of like neuronavigation. It's kind of like a modern way for the surgeon to be able to look at what is and where is he on the brain, on the surface of the brain. So there's like a little wand, and you'll see that in the video, and how you can hold this over the surface of the brain, and you can detect where the lesion is very precisely, and then you would be able to know where and what areas need to be covered either with depth electrodes or with grids. So just walking through this surgery, so obviously we have to make an incision in the skin, right? And then we have to, depending where it is, you have the temporalis muscle, which is underneath, and we kind of move that muscle, and then we make an opening in the skull. We take off that skull, we put it on the side, and then we go and open up the dura. Now, the dura is the leathery covering of the surface of the brain, and that helps to protect the brain. And we open up that dura, and you'll see this also in the video. It's shiny white, and we open up this dura, and we see the brain underneath it. Once we see the surface of the brain, we determine and we look and we take pictures, closely. We're looking for areas that maybe we see lesions on the surface of the brain. Sometimes you do. Sometimes you don't. Once we determine, we have the brain here, and these are areas that we feel that we saw the seizures coming from preoperatively, those are areas that we really want to cover with these grids. Now, what are these grids? And I wish I could show you this video because it would be so self-explanatory. Now, these grids are little plastic grids, okay? And there are platinum electrodes in each grid. So it's kind of like taking clear plastic, a clear flat plastic, and placing within the clear plastic these platinum electrodes, and these platinum electrodes are connected to two wires or one wire, and then this would go off and go outside of the patient, and then we might position several of those on different portions of the brain, and then we can very accurately see where they're coming from. These are co-registered with numbers, and you'll see on the video there's little numbers, 1, 2, 3, 4, and we can map very accurately where the seizures are coming from, because now we're directly on the surface of the brain, and we can tell what areas need to be removed and what areas we want to leave alone. Other things that can be done with this grid is we can also stimulate areas, so stimulate motor, sensory, and we can map where everything is before we go back for the second procedure or the stage 2. So that would kind of be the stage 1, and then stage 2 is where we go and we remove. We have several different instruments. One of them is a CUSA, is a Cavitron ultrasonic aspirator. It helps to remove brain without injuring it. And so what we do is we remove the portions of the brain that need to be removed that we believe are generating the seizures. We'll leave a drain. You'll see on the video, I always leave a drain. I love leaving the drain. This drain is very useful. It has been shown in multiple studies to decrease, because if you do, say, a hemispherectomy in the pediatric population especially, so they can be prone to, or there's a higher propensity to developing hydrocephalus or the need for a shunt. And so I always leave a drain inside for a couple of days until everything clears out from the cavity that's left inside. The cavity is filled with saline, okay? So the area of the brain that was removed, we put saline inside, and then we close the dura back up. We put the bone, and we attach the bone with mini plates and screws. We close the scalp, and you'll see on this video, it's very neat at the end.
For the drain that you're talking about, do you have to go back in then to remove it, or does it?
No. I just slide the drain out, and I leave a suture inside so I don't have to poke the patient again. Okay. And I think the patients are always very pleased with that. Okay, great. Go ahead.
Oh, doctor?
Yep.
Yeah.
Yes. What can you put a percentage on or a thing on how, like what's the number of infections that might come by with this procedure? You said there was a chance of infections. Is that like really low, or is it kind of medium?
It's very low, and I can tell you that in my hands I have not had an infection, and I've done a ton of these procedures, and I think if you're very diligent, careful, and I am almost OCD when it comes to cleanliness, and I thank God that until this day I have not had an infection.
In the business of stroke, what causes the stroke? The blood leaking out, or what causes?
Well,
common or no?
Sure. What can happen, and when you watch the video, you're going to see there's very large veins that are on the surface of the brain, and there are very vital veins, right? And if the surgeon is very cognizant and knows his anatomy well, then you will not have a stroke because the surgeon knows and should leave those alone, right? It's only when those are removed that the patient can suffer a stroke.
When the veins are removed?
Either the artery or the vein. So you can have a venous stroke, or you can have an arterial stroke, which would be likely less common in this procedure. Probably more common is that people will take specifically, and you can Google it, the vein of Lebet, and that's the inferior, that's the lower draining vein off of the brain, and it's a very important structure, and you don't want to take this vein ever. And when you see the video, you'll see this vein of Lebet. You'll see it very nicely. We shot it very nicely, and you'll be able to take a look at it. And because these are things that I always like to show patients, right? So we probably have to be very careful about where and what's taken out. So if there's seizures that are coming from behind the vein, right? So we can't just be cavalier and just say, okay, let's remove the vein. No, I would say, well, we should leave the vein where it is, and we should then remove tissue from the back of it. But you don't want to ever take that vein. So
worst case scenario, if there's some by chance there is a stroke while the patient, what do you do about that then? If all of a sudden this guy's having a stroke, how do you get out of that?
Well, you likely would not have much of a problem, and the reason, as long as the person has left a drain inside the brain, well, it'll probably just drain some more cerebrospinal fluid, push the brain forward, and the worst sequela would probably be that there would be more loss of vision. So one of the things, if you do an amygdalo-hippocampectomy, or you remove the amygdala and the hippocampus when you're doing this temporal lobectomy, removing the temporal lobe, right? So a lot of times, if you go back sufficiently enough, you're going to remove some of the optic radiations that go towards the occipital lobe, okay? And classically, traditionally, this is known as the pie in the sky. So in neurosurgical jargon, it's called a pie in the sky. So there'll be a little visual field, a defect, up in the upper contralateral, or the opposite quadrant of this patient. It'll be like a little pie missing up there. But what's very interesting is that it does not stop a person from driving. This does not prevent the person from driving, because a human being, when he or she looks forward, they usually use the inferior visual field, not the superior visual field. So if one were resecting, say, doing an extratemporal, like parietal lobe resection, there you have to be very careful, because if you take from the top of the brain and you get down to the fibers that are traveling to the occipital lobe, you interrupt them, then you're going to have an inferior visual field defect, which can be quite devastating.
And he can't recover from that at all? That's not recoverable? I mean, can he get better from that or no?
Get better from that? Well, I think it all depends on how big the stroke is, and that would have to be case by case. I can tell you that I have not in any patient I have not seen a stroke. I think as long as you leave veins and arteries alone and you remove just brain tissue, because the arteries and veins are not causing the seizures. So if you leave those alone and you remove the other structures, then you'll never have a stroke in anybody, Right. So.
And were you actually asking about the visual field defect, not so much the stroke, in terms of how? Is that a permanent visual field defect?
Oh, yes, indeed it is. Indeed it is, yes.
And how common is that in temporal lobe surgery?
I would say in probably 80 to 90%. The superior, not inferior, in a parietal and in the top of the head, if there's a procedure on top of the head, but in temporal lobe surgery, I would say 80 to 90% are going to have a slight visual field defect, and that's kind of, I quote in all patients, you're likely, I just say you're likely to have a superior visual field defect, but you probably won't even notice it. And a lot of them never do. They never do. And the reason is that the human, right, when you look, you usually look down. You don't really look up, right? So you always look towards the ground to make sure there's nothing in front of you. Usually, a lot of times you don't really look necessarily up. And it's because it's so small that defect is really unnoticed.
Okay.
But you had another question.
Doctor, I have another question, please.
Yeah.
Between the patients that have two surgeries, what is the reason for the second surgery, and what is the timing between the two?
So I'm going to put it on a very easy scale. So say you come in, usually I do this on a Monday. So usually on Monday is when I do the stage 1. So you already went through phase 1. Now you're in phase 2, right, of being evaluated. So we go to the stage 1, which is where we're going to do the long-term 24-hour EEG monitoring, okay, with the electrodes on the surface of the brain. We go in for surgery on Monday. We go to the ICU overnight. The next day we go to back upstairs to the EMU, to the epilepsy monitoring unit, right, for 24-hour EEG monitoring. Usually, most patients, I can tell you, I take them back on Thursday. But I will tell you one example. Right now I have a young female here, and she's probably going to wind up staying until Monday because we have not collected enough data on her that I would feel it's safe to just go ahead and remove the portion of the brain. So we're probably going to extend it to Monday. So I think that is usually Thursday, on nearly every one Thursday, but there are exceptions. So for the surgeon and for the neurologist is always the safety for the patient. We want to make sure that we have enough data because that will give you a higher outcome of being seizure-free, and which is the goal. So we want to make sure that we have sufficient data that we can be very precise and remove a limited amount of brain tissue with a good outcome.
Doctor,
I think
I have a
just a second. I think your question was if you have more than one surgery, what is the reason for having a second surgery? Like, let's say you have one,
the second evaluation surgery,
or later you have another one. What would be the time between those, and then what would be the
between
reason
those
for
two,
having
right?
A second surgery?
Oh, okay. I'm sorry, I misunderstood. Well, I can tell you that it all depends on the severity of the failure of the first surgery to control. So if in a year after being evaluated for 6 months, your seizures are worst after the first surgery, you should most definitely get the opinion whether or not to have a second surgery done. I wouldn't go past 6 months to a year. I would be very hesitant if there's lack of control and things are not faring very well, and we think that this is in an area that could be safely resected. We should probably just proceed with that.
That's how I was here. This is Clinton. That's how it was with me. I had my first surgery, and I went 2 years down the line, and then there's no better. Like I said, uncontrollable before I had surgery again.
Okay.
Mm-hmm.
Other questions before
I agree. I think, everything should be really evaluated on a case-by-case basis, depending on the area of the brain that's being affected. And, and I don't remember your name. I'm sorry. The one that you were operated in at Children's Hospital.
Clinton.
What was that?
Quentin.
Yes, Quentin. So as Quentin, very eloquently put, he has a vagal nerve stimulator and he's doing great. And so, I think everything really needs to be very carefully evaluated, even whether to have the second surgery or consideration for a vagal nerve stimulator.
Okay. And now, after the surgery, about how long is the typical recovery period, and how many cases do people need additional rehabilitation if there's any deficits as a result of the surgery? And in regards to the length of stay, the average that we have here at Beaumont is probably between 4 and 6 days, average of 5 days. 5 days probably, based on our data. Usually if the patient is younger, they spring back very, very quickly, and they recover very quickly, and so the stay might be less. If they're older and there's other medical issues involved, they might stay a little bit longer. In regards to getting care after the surgery, it all depends what was done, but if we think of a straightforward temporal lobectomy, they probably do not require much care afterwards, as long as they have a family member with them, for at least 2 to 3 weeks. So they don't need to go for rehabilitation. The reason is that patients that need rehabilitation are those that might have some weakness or other sensory deficits or visual deficits, things like that. Extratemporal lobectomies are more common, or corpus callosotomy. Okay.
But usually with straightforward lobectomy, you won't need to go for like a long-term care facility or even short-term.
Okay. Someone had a question?
What is roughly the percentage of the patients after lobectomy that can drive? Rough percentage.
Rough percentage, probably 80 to 90%, I would say, easily.
Mm-hmm.
Easily. I would be hesitant to even think that there's someone that went through this and was not able to drive due to a visual field defect. I can't really even think of someone right now.
Okay, and what is the amount of medication that the patient has to take after the lobectomy?
So
is it decreased?
The medication, usually they're put on the same medication that they were on preoperatively. So if you were on, say, 2 medications preoperatively, they will be continued for at least 6 to 8 months, and they're slowly weaned down. So it's not weaned down, say, in a week or stopped. It's continued for probably for 6 to 8 months.
Okay, and there's one more thing, because when will actually the memory start to improve?
If
there is such a process.
So memory would improve as the person starts getting better. So a lot of times people do not even remember, and I always ask, I'm always very curious, how and what do you remember while being in the hospital? A lot of people can't even remember anything of the hospital. And that goes for just even other brain cases as well. And I just think it's the entire environment of being here, being woken up constantly by the nursing staff and medicated and things like that, and not having really anything to do with the actual procedure itself. I would give it at least a month in order for things to really start healing up better, and at least 3 months for a full recovery back to just doing whatever you were doing.
I was asking this because now I have some problems with the memory, and I suppose it's based on medication. And for long-term memory, this is what I'm talking about.
Long-term memory.
Yes. So I don't know how would that long-term memory will improve after the surgery.
Yeah, well, related to that, maybe I can add to that, because there's a possibility as a result of surgery that memory could get worse, but there's also a good possibility that it could get better because of reducing seizures, because of reducing medication and maybe not having as many side effects. And also, if you could talk, Dr. Colen, about the idea that basically some types of epilepsy can almost be progressive, and you almost see cognitive decline the longer you have uncontrolled seizures, and by stopping that process you can improve or at least stop the decline of memory function. Can you talk a little bit about that?
Russ, yeah, what I have seen especially is speech function. So evaluating more because it's a lot of times it's very hard for the neurosurgeon, maybe the neurologist, or a neuropsychologist, and it's very important to have always one of those on the team, and they might have notes to that effect. But I can tell you something that I have noticed, and I always try to document, is how their vocabulary whether it has improved or worsened. And I have found that a lot of patients that have had chronic seizures, their vocabulary in particular significantly improves.
Okay, thanks.
So it's hard to really be able to pinpoint. I think it's a great question for a neuropsychologist in that regard, but I would be very hesitant to really quote anything from the literature because I'm not very well versed on that.
Okay. Doctor, I have a brain tumor, and I'm told that my epilepsy is inside the tumor. Is that possible? Is that operable?
It depends where it is in your brain, it all depends, right? So it's very hard for me to say, yeah, of course it is, where I don't really know. Is this in an area of eloquent brain tissue that if we're operated on and this, focus removed or this tumor removed, would it cause any harm to you? I'd be happy to talk to you afterwards, and and we can discuss your case in particular. But it's true in regards to general. So if we could remove the tumor completely, your seizures, you won't have any more seizures, right? Because it's the tumor that's causing a lot of gliosis, a lot of irritation to the surrounding brain, and
remove the epilepsy. Is that what you're saying?
You would, yes. You should improve completely from your epilepsy if the tumor is completely resectable. But it all depends where on the brain it is. But I'd be happy to talk to you and we can review it further.
Well, when a lot of people and a lot of the literature reports seizure-free rates after surgery, do those typically count simple partial seizures or seizures that don't affect awareness or consciousness? Because I hear a lot of people saying I'm seizure-free as a result of my surgery, but then they also say, well, I still have auras every once in a while, which is actually a seizure. So does in the literature, when they report 70 to 80% are seizure-free as a result of the surgery, is that really seizure-free, or is that just free of seizures that affect consciousness?
Well, what a lot of the literature reports really look at is, did it improve the patient? And so what was their initial presentation with, and was that improved? Mm-hmm. So in other words, if someone, so it's a kind of a loosely defined term for just a seizure, right? A seizure, you can have so many semiologies for seizure, right? And if someone presents with hallucinatory type auras, and that is their seizure, and they're getting that 7 to 10 times a day, and you've reduced that, and that is completely eliminated, but now they might have something else. Is that termed as being a good case, meaning a case that now they're seizure-free? A lot of literature reports, at least, yes, they do. They say yes. Okay. So you have to evaluate everything very, very closely.
Yeah, and I guess a lot of that depends on the neurologist too, because some neurologists will advise their patients that yes, it's okay to drive if you have only simple partial seizures, whereas others, according to the law, specifically as it's written, any type of seizure, you're not supposed to drive. So a lot of that would be something you'd want to discuss with the neurologist as to,
because you're right, and a lot of what I have seen based on my experience is that if you don't have a mental status or type of event that could potentially lead to, say, a fatal accident or something like that, and it's only, say, an aura, what I have seen, a lot of times they'll say, well, you can still do what you have been doing. You're going to have this type of discomfort, but as long as you feel that you would still be able to continue with your normal duties, then, a lot of neurologists feel safe, and they don't want to take away the keys, But that's... No, I would say that it's all dependent on the neurologist.
Right.
If you have an aura, but should you have? I have auras, but I don't have seizures after aura. I have seizures without the aura.
Mm-hmm. Okay.
I have grand mals without the aura. I have just all of a sudden but then I have auras without the seizure.
Mm-hmm.
Okay.
Well,
in other words, should you normally have auras and then a seizure?
Not everyone. Do they correlate or no?
Yes, that's what I'm talking about.
They don't correlate.
No.
Mm-hmm. So one thing that might be interesting, and again, this would need to be evaluated, is do you have two different seizure foci? In other words, two different areas of the brain, one that's causing the aura, and then the other one that's separately igniting. Is there a threshold or where the aura gains enough strength that it later ignites a tonic-clonic seizure? And, it's very difficult unless this is really evaluated, and this is why, I strongly always suggest, going to an epilepsy monitoring unit or some comprehensive center where there's a neurologist that would feel comfortable interpreting, what he or she finds.
Could that be monitored? Could they find that out and monitoring that, something like that?
Because even if you have an aura, so something that you have the little button in the epilepsy monitoring unit, you could let them know, and they can look and they can see whether or not it appears to be that you're having seizure activity and where it's coming from, which would be important. And then when you have your tonic-clonic seizure, obviously it will be important to look and see where is that activity coming from, and do both of those correlate.
Yeah, right. Okay.
If someone is considering surgery but they don't have insurance, or maybe they have very limited insurance, are there any resources to help them pay for surgery, or is that just simply not realistic for someone to have surgery if they don't have insurance, or if their insurance is just not good?
Well, no, you know something. I even take Medicaid. I you know, just being here at Beaumont, we accept essentially, you know, pretty much anything. You know, I would say for us, I don't believe there's any insurance that wouldn't be thought of as really not good insurance. So we pretty much accept anyone's insurance. In particular, I don't know, you know, all the ins and outs of insurance companies and how things can change, but you know, we have gotten approval for pretty much all of the necessities. I can follow up with Renee and follow up even with my office and find out, but I strongly believe that we try to take care of whoever it is that needs something, and I personally never even look at that.
Right, but if someone has no insurance, then
it's difficult. Now something that always can be done, right, always, is that if it's considered emergent, right, the person would come into the hospital, but then they would have to be willing to work with, say, the clinical health specialist on the insurance. There's paperwork that you have to go through, and you can get insurance while you're here.
Right. And
you know, other avenues that we have explored are, you know, philanthropic type donations, and you know, that's something that we have always looked for, and from the like Beaumont Foundation and things like that. But this is more on a case-by-case basis, you know. It's not like just pretty much anyone, you know.
And are there clinical trials ever that people can enroll in if they don't have insurance, and maybe that would be a way to get surgery, even though it may be an experimental type of surgery? Or
Most certainly, because if you enter into a clinical trial, you absolutely, as long as you qualify, then there's all these criteria for the clinical trial. And as long as you fulfill the criteria that the specialists are looking for in a particular clinical trial, everything is paid.
Right.
I got a question for you. Mm-hmm. I've had surgery, and my thing is, when I bend down, it don't happen all the time, but I get lightheaded. Mm-hmm. Is that common, or is it? Have you heard that before?
When you've been down?
When I bend down, like I work part-time, and I work out on the golf course, and like when I'm bending down, picking up sticks and stuff like that, I get more lightheaded than I normally did before I had surgery. And it just seems like it's coming from the right side where I had my surgery from.
Well, we would know that there's nothing in there but fluid, right, that fills that cavity. Whether or not this has anything to do with flow dynamics of the brain, it's really hard for me to be able to say. And, you know, and obviously it would be important to look at an MRI of your brain just to make sure everything looks good. There's no cysts that are forming there, things like that.
Okay.
And the other thing to keep in mind, too, is that it may be completely unrelated, too. I mean, if you're bending down and then getting up suddenly, or if you're laying down on a
could be your heart.
it could be a vascular thing that is fairly common and benign. So it's go ahead.
Yeah, but like say, before I had surgery, I didn't notice it, but then after I had surgery, I've had surgery back in late 10, like say October of 10, and last summer when I was working, when I was bending down and stuff, I noticed I started getting lightheaded more. And I started back to work this year, and I've noticed I've been getting more lightheaded again. This year when I'm bending down, picking up sticks, picking weeds, picking up stuff like that on the golf course. And like I said, 3 years before I worked on the golf course, before I had surgery, I never had that problem. I don't know if a lot of people say you're just getting older, Matt. Okay, well, maybe I'm getting older. I know I'm getting older, but I don't know.
Excuse me. It might be, could be vascular. It could be. I think it's really hard for me just to be able to say, well, it's this. I feel that this is something that should be evaluated probably by a physician, just to make sure that everything is good.
Right. Well, I just didn't know if your other patients have complained about being lightheaded too, so that's why I thought I would ask you.
Well, I think it's a good question. I don't know the answer to exactly your question at this time, is what I would say.
Okay.
Okay.
I have one more question, please. I was scheduled for a lobectomy, and I want to know what is the... I didn't understand very well. What is the reason for an eventual second lobectomy? So what could be the cause?
Well, I don't think that one should have a planned second lobectomy.
No. If it will be scheduled, I mean, if I have to go like in a year to restart the entire process, the WADA test, the electrodes implanting and all that stuff, and have the second lobectomy. So what would be the reason for that? I mean, could the seizure come back, or would be some different reasons?
Well, 75 to 80% of patients are improved from their seizures or seizure-free after this type of surgery. In failed cases or cases that the patient doesn't respond to, sometimes there can be an extratemporal source that is igniting the seizures.
So I'm guessing that it's rare that...
Do you think I answered your question accurately? No? Maybe?
I have... So the source of my seizure is in the right temporal lobe. But with the electrodes, they seen something on the left side too. I am scheduled
something? You listen to this. So, sorry, I get so excited all the time, but I can tell you that there is a theory of mirror temporal lobe matching with someone that has this type. Now, did you have depth electrodes implanted?
Yes.
Yes. And bilaterally?
Yes.
And do you know, was there so and you might not know this, but importantly would be to look at milliseconds difference from one side to the other. Do you know, right. Did they say that it's probably coming from the right?
They said that most certainly they come from the right, and on the screen there were 10 lines for the right side, 10 lines for the left side to monitor them. And they told me that there is most certain coming from the right, but there is something also that generates in the left side.
Well, I don't know specifically But we just had a publication at the American Epilepsy Society in regards to exactly what you're describing. And a lot of these are thought to be non-surgical cases, and we kind of have showed that, yes, these are probably and very likely surgical cases as long as they're looked at very carefully from the millisecond standpoint. So we have done complete right-sided lobectomies in patients that it appears to be bilateral, and in actuality, it's just mirror imaging. There's a theorist who believes that this mirror type of seizure is actually just a very rapid spread through a tract from one side to the other, and then it appears that it's bilateral.
During the surgery, so should be separated the left from the right in order to stop these, or what is the usual procedure for this?
Amygdala hippocampectomy. So anterior mesial temporal lobe resection.
Okay.
So and safest. Are you right-handed?
Yes.
Yeah. And do they get an MRI?
Yes, everything.
Yeah.
So they didn't see anything on the MRI for the left side, only on the right side.
So they saw something on the MRI on the right side?
Right.
So I strongly believe that a right amygdala hippocampectomy would probably cure your seizures.
Okay.
And this is very preliminary. I haven't seen all the data, but and based on even our article and presentation, this would represent exactly that case that some people are hesitant to take on, but would be responsive.
Okay. Thank you very much. Yes.
So let's see. What would you say, in addition to obviously improvement or reduction in seizures, what are some of the other benefits that patients have reported in terms of quality of life and other improvements as a result of their surgery?
Well, going back to work obviously would probably, be fit within the quality of life, but, not having the stigma of being always concerned and very nervous about having a generalized seizure in public is another one. Like I mentioned earlier, their speech, this improvement of speech is probably the highest on my list.
And can we talk a little bit about some of the newer surgical therapies for epilepsy and what we know about them so far? A lot of them are in clinical trials right now, but there's gamma knife surgery, there's the responsive neuro stimulator system by NeuroPace, there's deep brain stimulation, or also Medtronic or Sante it's referred to as well. And then there's people have also talked about, or a lot of people have asked about using lasers in surgery. So if you can talk about some of these new approaches and techniques and what we know about them so far. And then if there's any others that I haven't mentioned that are on the horizon, that would be, I'm sure people would like to hear about that.
Certainly. Well, starting with the gamma knife radiosurgery. So gamma knife is essentially targeted, stereotactically targeted radiation. So focused beam radiation, high dose, very, very high dose. Essentially what you want to do is you're almost like burning a hole into the brain. And, this again, as you mentioned, is still experimental. The center that has the most literature published on this would be Pittsburgh, and and now I read another recent article that was out of Virginia, but I would still recommend Pittsburgh as probably being the most cutting edge place to go for this type of therapy. the target for the gamma knife radiosurgery. So gamma knife radiosurgery. So what's done is a frame is fit onto the head, okay, and then the patient goes into this helmet, and there's cobalt beams that travel from all sides, and they converge onto this one hot spot that one wants to really target. Well, one concern is there sufficient space, number one, for the brain to swell after receiving this radiation treatment, because parts of the brain are going to die, right? And then what's going to happen is you're going to have a lot of brain swelling. So this has to be done very, very cautiously, and again, there's even more parameters that need to be looked at other than just delivering the gamma knife radiation to a tumor. So to a tumor is a very low dose compared to the gamma knife for epilepsy surgery.
Right.
Again, the target for this is the hippocampus or the amygdala/hippocampal formation area, and there have been fairly good outcomes. What are the benefits of this type? Is that you don't have to open up the skull. What are the downsides? There's no necessity for invasive monitoring, and so you might miss a crucial area of the brain that needed to have been removed and was not targeted.
Right.
The NeuroPace, I'm not completely familiar with, but I can tell you that from what I have read is that this is a clinical investigation or a clinical study, and it's called the RNS system. I'm not really familiar with the RNS, what it stands for.
It's responsive neurostimulation.
What was that?
Responsive neurostimulation.
Responsive neurostimulation. But from my understanding is that it's designed to look for areas and suppress seizures before there's any seizure activity. This is again invasive, and it's placed within the skull, and this pulse is delivered by a neurostimulator.
Any other surgeries or new approaches that you're aware of?
There's the deep brain stimulation that again is also still under test, a lot of testing. Whether implantation and the goal, a lot of the goal here, a lot of is just towards the anterior thalamic nuclei, or targeting towards the anterior thalamic nuclei and stimulating that, whether that might help to interrupt. And obviously something that's very known is the circuit of Papet, which is a circuit within the system of the brain that goes around and around through the amygdaloid hippocampal complex, and it circulates through the fornix, comes around mammillary bodies, anterior thalamus, and so the anterior thalamus is the point of stimulation for the deep brain stimulation. I think again this is more of a palliative type procedure, and I don't recommend this as a first type procedure. So someone that has failed surgery, then I would recommend deep brain stimulation or vagal nerve stimulator. That's usually my first take on my recommendations there.
Well, excuse me, that's what my doctor spoke upon. That's what my doctor spoke upon. Dr. Watson, I realize right now, Dr. Watson. See, I had surgery. Your doctors follow up on the records and everything. And see, he saw that I had surgery twice and everything. We talked to him. I've been talking to him, yes. We said, I think it'd be better to get a vagus nerve stimulator put in you and everything. And like I said, I just feel if you're coming on, cut it on with the magnet, it stays on for the minute and stops it.
Mm-hmm. Mm-hmm.
Any other questions about epilepsy surgery? We covered a lot of information, so I want to make sure we have some time for questions.
I do. This is Judy. I'm trying to understand the hippocampus. Do seizures damage the hippocampus, or are damaged hippocampuses causing the seizures?
Yeah, it's a great chicken-egg question. That's a very tough question. Go ahead.
Well, my hippocampus is now half the size that it was. Mm-hmm. And that and the MRI showing some spots and the neuropsych eval all leading to, the temporal lobe epilepsy. And it's the left hippocampus. I'm just trying to find out, is it the hippocampus that is doing it, or are the seizures doing it to the hippocampus?
Well, at least what's thought, and again, there's a lot of different schools of thought, but from my understanding, so someone that might have had someone that might have had hypoxic events when they were younger. So one example is if they had like a febrile seizure when they were younger, and heat can damage the hippocampal neurons. So neurons in the hippocampus, they are very, very, very sensitive. Okay, and so some of them can die, and then when they do die, and there is kind of scarring, what they call the mesial temporal sclerosis. So this is likely what is igniting, right? So there's kindling in the transmission. There's neurons that are missing, and this will help to kindle the seizures, and that's why some of these people do have seizures. And we do know that if we look at an MRI, their hippocampi are small. So especially on one side, when you compare it to the other side,
right?
Small.
So you think it's more the kind of the process of epileptogenesis, the process of the brain becoming epileptic? It's kind of the consequences of that initial injury or insult to the brain?
Yes.
Okay.
And obviously the other population would fall under children or children that are being born and kind of got stuck midway, and there was difficulty with the birth, and there was hypoxic events, or there was meconium or things like that, and these hippocampal neurons, especially in zones 1 and 4, and you can look this up online. Zones 1 and 4 are extremely sensitive to hypoxia and heat. So children that have febrile seizures, it's not like they're always going to have a seizure later on in life. Most of them do not, but it can damage areas of the in these areas 1 and 4 of the hippocampus that later can ignite seizures.
So you're saying, in your belief, then, it's the hippocampus that is igniting the seizures.
Correct. Yeah.
And so if my hippocampus was getting smaller over the last 5 years, and I'm 50, why would it be getting smaller?
Well, you have to be very careful, right? And obviously, just normally, as we grow older, there's normal brain atrophy, right? There's just normal atrophy of the brain, and one cannot be quick to say, oh, well, this person has, mesial temporal sclerosis, and this person needs to have a surgery. No, that's wrong thinking. So obviously, if the person has disabling seizures that are not being responsive to medication, that's when I would recommend that this patient be evaluated for a possible surgery.
Right. I had been in the monitoring unit. I'm one of the ones that went in there for the 5 days and did not have a seizure.
And you didn't have a seizure. Now, did they try to evoke seizures?
With light.
With light?
Yeah, with light.
And did they ever give you any medication to try?
No. No, I was down at DMC and they did not give me medication to try to invoke them.
It's tough to be able to say, well, they took you off all your medication, your seizure medication?
Yep. I was off all the meds when I went in.
And what kind of seizures do you have?
Complex partial.
What are do you have Onora?
I'd say probably 70% of the time I have an aura.
Could you describe that semiology?
The aura with me is I will feel like a tingling around my head.
Tingling around?
And, a tingling almost like, the tingling you get when you're falling asleep in your fingers or something. I will start to get that, and then I will notice a slowing of my thought process.
Loss of consciousness, collapse, or
nope, I don't
sleep or anything like that.
Nope, I don't typically fall asleep. I don't typically collapse. For the most part, I'm rigid. I tap. My fingers tap or my toes tap. And then of course it went and changed about a year ago where I started babbling.
Well, I think you probably need to be evaluated for a period by a neurologist and decided whether they should wean the medication before you even go into the EMU. Now, the question being is that if you are fairly well controlled on the medication, why even go through this, right? Because then I would say, well, things seem fairly well controlled, and why have the surgery?
I've been on 6 different meds, and none of them have controlled them.
Well,
one of them slowed them down more than others, but never controlled.
Well, I think, you obviously need to be evaluated a little bit further in order for me to be able to determine whether or not you would be a surgical candidate. Unfortunately, on the phone, it's hard for me to be able to say, well, certainly, but,
right.
As long as, and I'm sure we would be happy to help, however we can.
Okay.
Right, and some of it, again, just might be bad luck. You just didn't happen to have a seizure while you're being monitored.
Okay.
So if you tried again and maybe went to a different place or tried a different approach, you might be able to get one and learn more about where your seizures are coming from. So.
Right, and unfortunately, it's a very costly process.
Yeah, right.
And that it's kind of at times the cost is prohibitive.
Right.
Of keep going into the monitoring units.
Sure.
Right.
I understand the necessity, but I also, again, and a little standoffish at the cost.
Right.
Even with insurance.
Yeah.
I think somebody needs to come up with one that, you can have be hooked up at home for a week.
There is ambulatory EEG, but has anyone tried to come up with that type of technology, an ambulatory EEG that also has, just a standard
video
camcorder or something that can be used at home? Something that would sync the two up?
Yes and no. And one of the reasons that the neurologist always would be very hesitant to take a patient off of the medication while at home,
right,
due to the medical legal
right.
Implications of having that done, and they're not being monitored closely, and God forbid, they could be a danger to someone else,
Well, great. I wanted to thank you, Dr. Colen, for your time and sharing your expertise with us. This is very enlightening, and hopefully everyone learned something new today. So thanks again, Dr. Colen, and thank you everyone for joining us.
You're very welcome.
You're welcome.
Have a good evening.
Thank you.